topic. I'm Jim Nickman, I'm president of the foundation. I really want to welcome you to the event. I think it's an important event, and it should be stimulating. I should say right at the start that Jason Halverson couldn't make it at the last minute. I'm not sure what exactly would happen. I'm sure the governor wanted to see him, but he will not be able to make it. We're really disappointed. But that does, the positive is that it does allow more time for interaction, and I think there's potentially a lot of interaction that our presenters will elicit. So we'll do that, and again, we'll miss Jason, but we'll take advantage of the extra time. I want to say I think this is, we're really pleased to have supported this project. The state is about to go on a long venture and adventure to think about payment reform, and it should be, it's an important thing for all of us in the state to be thinking about and involved in. And I'm one of those types of things that measurement is important. You need to measure things if you want to track them and see what's happening. And the scorecard is surely an important tool, I think, that we can use as a state to track where we are and what we're doing. So I'm not going to talk about it at all because I have a reputation for stealing thunder. I won't do that. I'll let our speakers do that. But the idea here, the idea is sort of get two presentations from Andrea, who really did a lot of the work at the Catalyst for payment reform. We really want to thank you and your organization for doing this. And also Troy's going to talk about it from the Department of Financial Services perspective and just sort of give his thoughts about where we're going in some ways. And I must say, we really want to thank DFS for their involvement. It couldn't have happened, I think, but it wouldn't have happened without their helping us get the data and the information, and always we enjoy partnering with you folks in these type ventures, so it's great. I'll say one thing is, just one other thing is it's, one of the neat things about this project is it does include the Medicaid data. That's the first of these scorecards that do include Medicaid data, and of course Medicaid is usually important to our state, so I think it's important to track that. So with that introduction, we're going to go through the presentations, have some questions, and then have reactors and some more questions. We'll start with Andrea.
Thanks, Jim. Can everyone hear me okay? Is that a yes or a no? Yeah. Yes? Okay. Thank you. So I'm probably going to stay seated for this, and I'll try to see faces if there are queries. I just wanted to start by thanking Jim and the New York State Health Foundation for commissioning CPR to do this project. It's really a pleasure to be here finally. April 30th has come, where we can release these information and so these data. So I want to thank David and Amy and Emily personally for really helping CPR get this across the finish line. So we couldn't have done it without you. I also, if you'll indulge me in a moment, just to take a few moments to thank some other people who, without their support, this project couldn't have been done. So Fung Kwan Soo, who is with the National Business Coalition on Health, is CPR's data partner on this project, and she was an integral, dedicated partner. Laurel Pickering, who you all probably know, she's not able to be here today, and she sends her regrets, but the Northeast Business Group on Health has really been a leader on payment reform, and they have in the past few years queried health plans on some of these very questions already through their annual evaluate process. So we thank Laurel and the Northeast Business Group on Health. Of course, the Department of Financial Services and John Powell for his leadership in helping secure health plan participation. And then of course, Paul with HPA and Tony Fiore working with the health plans and thanking the health plans themselves for their dedication and resources that they put into this project. And of course, our very small team at CPR. I'm going to talk a little bit about who we are, but we are very small. We're only 4 people, and but we like to think that we do a lot of good work, and we hope that here in New York, you'll find that we have. Is there a way to put this on full screen?
We're replacing the batteries in the maps.
Oh, okay, gotcha. Good, okay. All right, so I will keep going then. And I've got some notes here. So I've been working with these data for quite a long time now, and I'm quite familiar with them, but I want to make sure that I explain it in a way that is understandable and relatable for this. And this is a healthcare related audience, so some of these things should sound very familiar. Just a few comments about who CPR is, in case you haven't heard of Catalyst for Payment Reform. We're an independent nonprofit corporation that works on behalf of large self-funded employers, as well as state Medicaid agencies and state employee and retiree agencies. So it is a public-private sector group. We at CPR provide the thought leadership to and coordination among these groups on payment reform initiatives. And so we're able to do this, all of these groups, 36 groups coming together, creating sort of a critical mass of voices. You can imagine in the marketplace, if you're a provider, you're a health plan, you're receiving lots of different complicated, potentially contradictory messages about payment reform. So our goal is to send consistent messages into the marketplace. And one of the ways we do this is through a shared agenda. And in the red box that you see up there, I'm going to just focus on the shared agenda today, which is that CPR has a goal of 20% of payments proven to enhance value by 2020. So you'll see a larger number when we get to New York. And if you've looked at our national scorecards, you've seen a national number. But keep in mind that that doesn't necessarily include the proven part. We've just quantified the dollars flowing through it, and we have a big challenge ahead of us to quantify or to show the value and effectiveness. So I'm going to just focus on the scorecard part of our agenda. And you can see here we've done them nationally in 2013 and 2014. We did a California scorecard in 2013 and 2014, and New York is our next state. Released today, and as Jim said, this is the first time we've done a state Medicaid plan, and it was an ideal state to do that because of the Medicaid managed care here. So, as I mentioned, there's a generous financial support from the foundation for this and tremendous cooperation with DFS, Department of Health. And all of this was to work towards a common goal of measuring New York's progress on payment reform, particularly as it embarks on its DSRIP and SHIP initiatives. So the question is, what did we measure? And we measured what CPR calls value-oriented payment in the commercial and Medicaid markets. We use value-oriented, lots of people use value-based. You could use them as synonyms, although CPR really likes to use value-oriented because it's value-oriented is more directional. It's really not the base that we're talking about, so that's why we use that term. What data did we use? We used data that was collected from 10 commercial health plans and 15 Medicaid plans. I'll explain some of the exemptions from that in a moment. And why are these data important? Why are these results important? They're important because they do help New York set the baseline for its larger goals that it's set out for itself, and you'll hear from Troy. So here I just wanted to talk a little bit about the design. In 2012 and 2013, CPR convened a National Advisory Committee. This National Advisory Committee was composed of multi-stakeholders, plans, providers, employers, academics, leaders on payment reform, to really talk about what even is a definition of payment reform. We defined the scope, we defined terms, and we developed the metrics that were used for the scorecard you see today. We started our conversation with the foundation in 2013 about this particular project, and we started it in the spring of 2014. And so it was with that partnership with the foundation and DFS that we began to coordinate and collect the data. The official data collection period was from August of 2014 to September of 2014. There were some extensions that were granted, so it went beyond September. And if you think about that data collection period, that means that the data we were looking at was from 2013. So this is a look back on a calendar year 2013, or the most recent 12 months. Plans had that option and could note that, but most, if not all, selected using 2013 data. And as I mentioned, we had 10 commercial plans who participated. And the exclusions, I think it's important just, I assume there might be some questions about that. There are some exclusions on the commercial and Medicaid side. On the commercial side, for those plans that started operations in 2014, primarily for New York's Marketplace, they did not have operations in 2013 and therefore did not have any claims data to report, so those plans are excluded. Some plans also, if they were had acquisitions or have subsidiaries or freestanding subsidiaries, some of those plans, the parent company submitted a response on behalf of the subsidiary. And on the Medicaid side, we excluded long-term care only, behavioral health only, and duals only Medicaid plans. So if they fell into those only categories, they were excluded from the data collection. So now I guess I'll turn to the results. And in your packet, you should have two of these brochures. And they're going to be displayed here, so whichever is easier to read for you. But one is for the commercial market, labeled commercial market, and the other is for Medicaid. And I'm going to walk through the metrics on the front page, and I know some of this upfront matter that I'm explaining is a little tedious, but I think it really helps understand the methodology that we used. So when plans were instructed to respond to the data request, we asked for total dollars paid through the various payment reform methods, not just the incentive portion. Mostly that was because it's a tremendous administrative burden for plans to be able to dissect and take out just the incentive portion. So this is our methodology we use nationally as well as in California. So it's total dollars paid. The other thing is that we told them to list their dominant, put those total dollars in the dominant form of payment. So we all know that there are payment reform methods that might be hybrids, that are layered on top of each other. And where there is a layering, oh, did I not? I haven't switched forward. Okay. There we go. Thank you. Where there is a layering of payment reform, we ask the plans to say, how would you describe this? What is the dominant form of payment? So there is some judgment that was used here in that. So those are the two things to note. The other thing is that you might find these results pretty wonky. I imagine that in the audience, including myself, we've got some real wonks. It's not really a report that's directed towards a consumer-facing audience. So some of this is quite detailed. The top line number of what we consider to be value-oriented or what's based on fee-for-service could be helpful for consumers, but I just wanted to note that the primary goal here was to inform those plan, provider, stakeholders on where we are in payment reform. So this is our first metric. You'll find it in the center of the front page. And it's very important to New Yorkers, and as the state has moved forward with its initiatives, to find out how much does the commercial market still rely on the fee-for-service payment method. Also in the Medicaid market, how much does Medicaid still rely on fee-for-service? And so we tried to answer this question. So each section of the ring here represents a different payment method. The slide doesn't have the legend, but on your handout there is a legend for what each of those slices mean. The red, orange, and yellow hues represent those that are still based on fee-for-service. The dark blue slice is a collection of non-fee-for-service payments, and the gray is just payments unknown. There's a portion of which we just don't know. So the inner ring that you see there, that ties all of the fee-for-service payments together. And in the commercial market, we found that 94% of payment, value or non-value oriented, is still using the fee-for-service based payment method. In Medicaid, this drops to 73%, and when we get to sort of the breakdown of that, most of this is in their shared savings, but it's also, as I mentioned, this is a value and non-value oriented payment, and so the Medicaid segment reported a lot of bundled payment without quality, so that sort of is why their fee-for-service dollars or percentage is less. So I think the takeaway on this slide is that both sectors have a long way to go in terms of moving away from fee-for-service, which seems to be a goal here in New York. This next slide is really tells us what is value oriented, and I like to talk about this in terms of dollars rather than the percents here. So if you can think about this, is that in the commercial market, this shows us that 34 cents of every healthcare dollar is flowing through methods that are designed to either improve value or quality and in sometimes reduce waste, and this is what we call value oriented. So 34 cents of every dollar in the commercial market, and in the Medicaid market it's very similar at 33 cents of every dollar. The remainder, the 66 and 67%, is in either traditional fee-for-service or some other payment method that does not include quality. So to put this in some context, in our 2014 National Scorecard, which also looked at 2013 spending, it showed that 40 cents of every dollar was value oriented. So some of the qualifications, I don't think New York should look at this and say that you're lagging behind necessarily. Some of the qualifications we gave on our national scorecard was that it was a national survey, voluntary by plans. It might be biased upwards because those plans who responded are likely larger, and plans that have something to report will report it. So there's a slight bias upwards in our national numbers, and it also includes California. So you can imagine that California plans and the capitation that appears in California could bias the national results upwards. So if you adjust for that, New York's results at 34 and 33% are really right on par with the national results. So while this is good news, and I have to channel Suzanne Del Banco, our executive director here, in saying, you know, we really have to take a sober look and realize that tracking value-oriented payment and what's flowing through them is the first step. But we won't succeed unless we know if these payments are actually improving quality and improving affordability. So we don't have the evidence on that yet, and that is our collective next big challenge. So this shows the breakdown of the 34 and 33%. I've just taken a snapshot of this here, of the two largest. On the right-hand side of the handout, you'll see lots of drops falling down into the beaker, and each one of those drops represents a different payment reform method that makes up the total. And so if you look at the largest drop on the commercial plans, that means 23 cents out of the 34 cents, 23 cents out of every dollar is paid using fee-for-service plus pay-for-performance. So most of you know that pay for performance has been around for over a decade, and these results just really show that there's a flurry of activity in payment reform, but it seems to be in a method that plans and providers are most comfortable with, particularly on the commercial side, and they know how to implement it. This is not unlike our national results, where pay for performance was the dominant side in commercial as well. If you look at the largest drops on the Medicaid report, approximately 13 cents out of every dollar was in non-fee-for-service shared savings, and almost 13% was in shared risk. And so 26 cents of every dollar makes up those two largest categories in Medicaid. I think it's also important to point out some of the smaller drops that are on the page there. So with all of the talk about bundled payment and the promise of bundled payment, it didn't register at all on the Medicaid side. So Medicaid did report bundled payment without quality, so it's typical DRGs, case rates, things like that, that fell into the not quality side. It might spur efficiency, but it doesn't have quality component tied to it. I think on the commercial side, it's only 1/10 of 1 penny. So that's a very, very small portion of the commercial market, and very little or none on the Medicaid side on bundled payment. So if you also look at this graphic, you'll know that some colors are, some drops are light blue and dark blue. And the light blue drops reflect payment methods that do not put providers at financial risk. So it's a carrot only, it's upside only. The dark blue drops reflect payments that have sort of the stick also approach, and there's a financial upside and downside for providers like bundled payment. So if you look on the Medicaid slide here, you'll see that the shared risk is in dark blue. And this kind of leads us into the analysis of what proportion of payments is considered at risk or not at risk for providers. So we're able to look at how do the light and dark blue drops add up. This is of the value-oriented payment. So in the commercial market, 85% of the value-oriented payments are not at risk. If I say this another way, going back to the healthcare dollar we've been talking about, that means 29 cents of the 34 cents does not put a provider at financial risk. It's an upside-only incentive. This changes in the Medicaid market. A little more than half does not put providers at financial risk, but it also means that almost half does put providers at financial risk in the Medicaid market, and that's that shared risk we looked at. So if I want to say this one other way to make this a little bit more digestible, Medicaid is putting more dollars at risk with providers than the commercial market, proportionately. The next metric we wanted to look at is, and this was important to the advisory committee the National Advisory Committee, which is we wanted to understand the experience of hospitals and specialists and physicians. What are they experiencing? There's a flurry of payment reform activity. What's their experience? And so we tried to measure this, and when it comes to the commercial market, about 47, 46% respectively are going to a hospital and a physician. 47 or 46% of their total payment is value oriented. So they're experiencing quite a bit of their contracts being tied to value. In Medicaid, primary care physicians are experiencing more of their payment being tied to value, and this is consistent with an emphasis on primary care and creating financial incentives to improve primary care. But if you look at the outpatient setting on the specialties care, we found in both sectors that specialists have the least experience or least of their payment tied to value. So it's 15 and 16% respectively. We're actually not quite sure why this is, why the proportion of a specialist payment is the lagging behind in terms of it being tied to value. It could be that it's more difficult to implement on the specialist side. It could be that there's more of a vested interest in the status quo. But you can imagine that if more payment is subject to payment reform in that outpatient specialty setting, we might be able to reduce spending in both the outpatient and inpatient side. So on the inside of your folder is what we call our benchmarks. These are benchmarks to track progress over time. And one of the things the advisory committee wanted to understand was how is payment reform reaching members or beneficiaries in the Medicaid side. And so we actually, I think it's worthwhile to discuss the conversation that took place here on this particular metric, because counting members tied to a payment reform contract or tied to a provider who is engaged in a payment reform contract is a very difficult thing to do. Patients don't just see one doctor, they don't just see one specialist usually, or they don't just have one hospital visit to one place. Anything can happen. And so tracking that patient across all of those is very hard, and we have to be sure not to double count that patient. So the advisory committee really struggled with this, and we ended up taking a much narrower view so we could get a cleaner, more accurate count of members that are touched by a payment reform method through a provider. And so what you see here is that 15% of commercial health plan members are attributed to a provider who is engaged likely into a accountable care organization contract or primary patient-centered medical home contract. That's where an attribution method can actually take place, and the plans have used an attribution methodology to track that patient back. That's actually on par with the national scorecard, if you're curious, on the commercial side. However, on the Medicaid side, you'll see that 56% of beneficiaries are attributed to such providers, either in an ACO or patient-centered medical home, that there's an actual attribution method. So it's a much higher proportion in the Medicaid segment. I did some quick math because I know we usually talk about this in the percent-wise, but if you think about the plans and the proportion of covered lives here, I think it's also might be helpful to talk about it in enrollees. So my quick math was that on the commercial side, about 1.6 million of the 12.3 million that were reported in the overall scorecard are attributed. And on the Medicaid side, it's about 2.2 million. So those are just enrollees. Rather, I know the proportion might look much starker, but from an enrollee standpoint, there is a difference as well. The next few I'm going to go through pretty quickly. In this metric, we looked at outpatient payments only. And as healthcare delivery and payment reforms aim to emphasize more primary care spending, it's logical that over time you will have some sort of balancing out of the outpatient payments that go to primary care. And so in the commercial market, of the total outpatient payments made, 77 cents of every dollar goes to specialists and 23 cents goes to primary care. So on the Medicaid side, that shifts a little bit. You have 58 cents of every dollar going to specialists and 42 going to primary care. Proportionately, more dollars are paid to primary care in the Medicaid market. That's a balance that actually correlates with the previous metric on attribution we just talked about, that there's more attribution and value-oriented payment for primary care. Over time, I think if this is a metric that New York wants to track, you will see those sides of the balloon start to even out. This does not adjust for higher base payment that specialists may receive or utilization, but it is just the dollars that are paid. Moving on to the next metric, this is looking at quality as used as a factor outside of the fee-for-service system. So as payment models shift from fee-for-service and move into non-fee-for-service settings, you would expect that more of those payment methods are going to incorporate a quality component. What we found here was that on the commercial side, approximately, actually it's in both almost, approximately only 60% of those non-fee-for-service payments include a quality component. So over time, we'd like to see that percentage go up. If you're going to shift away from fee-for-service, you want to incorporate a quality component. Yeah, okay. The next metric, I'm just about done. So the next metric is, this is just applies to the commercial market only. For those of you who know CPR, transparency is a really important part to our overall shared agenda. And I'm just going to point out the first and last metric here, where we had 9 out of 10 plans say that they support and have a cost calculator or a transparency tool available to their members. Again, this was in 2013, so 9 out of 10 of the commercial plans. 6 out of those 10 reported that they are able to show the members specific benefit design, copay, co-insurance, where they are in their account balance, things like that. So again, this was 2013. I think if we were to survey this year, we might have 10 out of 10 plans, and we would see that integration with cost sharing increase. The big question here is anyone using them? And we actually weren't able to report on this metric this year because we didn't get enough plan data to report on it. Many plans are using vendors, and obtaining that data just was not available for us. So that's transparency, again, only on the commercial side. And our last metric is on hospital readmissions. So CPR includes this because readmissions can be an indicator of quality and efficiency, and Medicare changed its policy on readmissions and eventually getting to non-payment. So in response, hospitals have deployed strategies to reduce their readmission rates overall. So this year we found that in both the commercial and Medicaid markets, about 8% of all admissions are readmissions within 30 days for all cause, 18 years and older. So that's one that I think is a trend that's been going downward. It's going down on the Medicare side as well. So I think you can draw your own conclusions. I have some concluding remarks, but I can save them for question and answer. And thank you for your patience in listening to some of this detailed data. Really appreciate it. Thank you.
Okay, we're going to have Troy give us some of his thoughts and interpretations, and then we'll open up for some questions, especially informational ones, and come to our reactives and then more questions.
Okay. Hi again, my name's Troy Oshner. I'm with the Department of Financial Services, and we regulate the commercial health side of it. And I just wanted to say, on behalf of Ben Lawsky, my boss, thank you. Thank you to the foundation, Jim and David, for your support on this. Thank you, Andrea, for all the work that CPR has done. I want to say a special thank you to John Powell for all the work that he's done with the department. Really has been the driving force making this all happen. And I did want to thank Paul Masalak and the health plans, because the health plans have been very interested in this, very supportive, did a lot of work to make all this happen. So I'm going to be short because I am short. I know we're behind, and you can't see because I'm sitting down, but I genuinely am short. But I mean, we're here obviously because we care about consumers, and that's what's at the heart of this. And we all know, and I see, there's a lot of amazing people in this room. So I'm not going to tell you stuff you already know about how we pay too much for mediocre quality, and the whole idea here is to shift that, is to try to the triple aim, lower costs, better care, better quality. And we're Department of Financial Services is totally invested in the triple aim. And I will just say, my personal note, my journey on this started a bunch of years, it was like 9 years ago when I was just starting at the department. I can't believe I've been here that long. But I was listening to Stephen Berger, who's in the audience, who may not even know who I am, but I was listening.
We sat next to each other up in I'm not that old.
Okay. He was at the Rockefeller Foundation, and somebody asked him, so if you could do anything, what would you do? And I think a lot of people thought, close more hospitals, whatever. But that's not what he said. What he said was, you get the system you pay for, and that changing and aligning the incentives is absolutely crucial to doing that. And really everything that we're doing around SHIP, that's SHIP with a P, SHIP and DSRIP, and all of our work on the many different committees, integrated care, HIT, health information, and transparency, and all the different workforce, all that stuff is geared towards that end, but mostly focused on it is the value-based payment work that we're doing. So, as you may know, a year ago with John's work, we did a report that gave us a baseline. Where are we on value-based payment? And it was a great report, and I think what it showed was that really all of the plans are involved in this. There's a lot of payers that are involved in this, that are working on it, but it's still the minority of the game out there. That the vast majority of payment is still fee-for-service the way it always has been. And I think while we're talking a lot about it, we knew that it was baby steps. I think what this report does and why it's so important is that it gives us an updated view, and it also allows us to now compare where we are vis-a-vis other states. And I know, as Andrea pointed out, we have to take all these numbers with a little bit of a grain of salt, because we had all of our insurers participating in this, and in other states it was purely voluntary, so you're naturally going to have plans that were a little bit more motivated to report all the good work they're doing, so it may be a little bit skewed, but it does give us a really good and very important baseline in which to measure where we are vis-a-vis all the many goals that we have for DSRIP and for SHIP. So, and I would just, I'm going to turn it over, but I just want to say I think the good news is that it further reinforces that there is a lot of work going on right now, a lot of important work, and I think our job as the state is to really unpack that, see what's going on, and then trying to measure, what's going right, and what's working, what isn't working, how do we bring this stuff to scale, how do we as a state use our tools to help to kind of get out of the way when we need to get out of the way, and skid the gears to make things go faster, and what can we do to try to encourage more reform. So I just wanted to thank you very much, and it's a really important report, and I look forward to hearing the comments from this great group that you've assembled. So thanks.
Open it to questions. Yes. Maybe you can tell us who you are.
John Gordon, New York State Scorecard. Just two quick questions. One, just from a methodological standpoint, how do you account for someone like a North Shore or a Montefiore that has a captive insurance plan, but they actually still pay claims on a fee-for-service basis? That's the first question. And then the second question, you talked about what proportion of payments had a value-based component attached to them, but how many overall dollars, or as a proportion of total healthcare spending in the state is actually in play on that value basis? So if you've got a, say, a 3% upside downside, then only 3 cents are in play. Does that make sense?
Yeah, good question.
Can you repeat your first one while I'm looking for the second one?
How do you
account for like captive insurance plans that make?
Oh, a captive insurance plan who,
Provider owns insurance plan.
that's paying people. So the captive insurance plan, they reported their claims paid on a fee-for-service basis. It was, or their plans, it wasn't capitation. It wasn't based on a capitated basis.
Provider owns, yeah.
The provider owns, yeah, they were,
So even though, in a sense, Montefiore is capitated, you know, because it has a fixed amount of money, and it's allocating money, right? For service, you have to.
right. So, and you can see that in the capitation percentages, that they didn't report it on a capitation basis. It was based on the dollars paid. In terms of total payments, I'm looking at my methodology here, I'll have the total dollars on the commercial side was close to 30 billion. On the Medicaid side, I'll have to go back and look and see what the total dollars. This was the denominator you're asking about, yes. So
I'm actually interested in the numerator.
the numerator. Let me look that up for you. Thanks.
Thank you.
Yes.
Also methodological. So you look at total payments that included out-of-network payments?
No, this was, that's a good clarification. Sorry, it was in-network commercial only. No out-of-network dollars are included in here. Thank you.
Do you have a sense of how much out-of-network dollars are statewide?
I don't, but I don't know if the.
Yes, right?
One more methodological question. On Medicaid, the medical home payments that are being made to the providers, those were included in and drove the big numbers, I'm assuming, for Medicaid's participation in value-oriented payments?
It accounted for some. I think most Medicaid plans reported that actually in their P4P percentage, which if you look is actually not terribly high. It's at almost 4%, 3.7%. So most of that incentive was probably calculated or captured in their pay for performance. And if it was passed on, it might have gone through what was the dominant form of payment, which was shared risk or shared savings. If it was a shared savings base payment with an incentive payment on top of it, they probably put all of the dollars in the shared savings bucket.
Dan Lowington, Primary Care Development Corporation. Curious, two questions. First of all, you have the share of total dollars paid to primary care versus specialists. Do you have it as in a total spend of primary care, specialist, hospital, pharmacy?
From a methodological standpoint, pharmacy is excluded. Pharmacy claims are excluded from all of this, and separated out by.
Like you have it for specialists versus primary PCPs. What about the hospital?
A different denominator.
A different denominator, no. I mean, the raw data to show this was just for outpatient spend. It didn't include, the denominator didn't include inpatient spend. One could do the calculation for that, but, because the total dollars are there. But it was just, the metric was intended to show the shift in primary care emphasis, and less around the hospital side, but could be done.
And then the other question on the front page, 46%, and the related on the other on the Medicaid for total PCP payments at in value oriented payments versus the others. You said that you'd expect the specialists and maybe the hospitals to kind of creep up there too. But would that be the case? I mean, especially as you're driving more of the responsibility for total cost of care towards primary care, wouldn't it be more of a transactional relationship than with the specialist to kind of control those costs, and you just see it as a fee-for-service type of arrangement?
I think that's possible. I think we just really don't know the answer on the specialist side. So it could be that there's just not an emphasis there because the shift is moving towards primary care or other sites of care, and so it would be on the primary care side. Maybe that specialist number doesn't increase. I think it's a matter of dissecting the why. So if it is we're entrenched in the status quo and we like that, then that's one reason to look at it. It's another reason if there's actually shifting of patient care towards other physicians.
So I'm a little bit confused by one thing, and I was wondering if you had an explanation for it. So on the percentage of I'm just looking at commercial, the percentage of payments to primary care physicians that are value-oriented, 46%. But then when you look at the number of percentage of people touched by, it's 13%. So that's a pretty big kind of discrepancy.
Yeah.
Does this include non-users when you're looking at the percentage of?
You have to consider the front page metric is of your total PCP dollars. The inside metric is a subset of the member population, so it's a smaller. It's not counting the providers, it's counting the members, and it's a smaller, it's not of their total membership or of their total patient population. They are experiencing, some of these may be experiencing on the front page, fee for service plus pay for performance, and that's why it's at 46%, for example. But only a subset of them might be receiving payments through shared savings or shared risk when an ACO or a patient-centered medical home, and that population is smaller.
Okay, I want to take one more question, and then we're going to, okay, we'll do this way.
It's just an information question. So is there, I feel like there's a lot of, as the questions are revealing, there's lots and lots of questions. And so is there a companion report? I feel like the infographics are sort of not, so because it's such a nuanced area, it might be helpful to have a companion written report.
Yes, there's a method, for both report cards, there's a methodological document can be found on our website and the New York State Health Foundation's website. You'll see.
This almost is begging more questions than
You'll
it's answering.
You'll see numerators and denominators and the metrics that were used kind of spelled out in that way. And you'll also see inclusions, exclusions, scope, things like that are all in the methodology documents.
You might want to say that front next time.
And, and definitions.
That's okay. Actually, it might be interesting to put a little feature on both our websites. So if you have other methodological questions, here's what
It's a
you can ask them.
good point.
A little bit
For my next
I'm just a consumer, so shocking that I can make a point. But
Okay, let's move on. We'll have time for a couple more questions afterwards and get to our reaction panel. Thank you very much. It isn't simple fare.
No. Like I said, been dealing with these numbers for a long time.
oh my God, I know, we're delivering it.
Okay, we're really pleased now with three actors. And, I know you have lots to say. One question I want to put on the table for now or later is, gee, should we be focusing more on getting to higher value payments? The capitated elements and the bundled elements, or should we be getting more people into any capitated payments? I hope that flows through our discussion. But we'll start with Paul, who heads up our Health Plan Association. And again, we want to thank you for your involvement in this project.
Thanks, Jim. On behalf of the Health Plan Association, I would say that plans clearly are supportive of value-based payment and are supportive of the CPR effort that the foundation has sponsored. It was mentioned that that this was a joint effort with the Department of Financial Services, and I also want to thank them for melding together what started out really as a DFS information request, and then the foundation was trying to do a CPR request. So from a plan perspective, the fact that we were able to get the two together and only have one data request for the project is appreciated. The benchmarking that's provided from this effort is clearly a benefit, not only for us to compare ourselves nationally, but also then within the state. And I think that is something that is significant. My observations on the report is that, this was based on 2013 data. As we sit here already in 2015, I would expect those percentages and numbers to increase. And I am aware, having talked with some of our plan members, that deals that were in effect in 2013 that may have covered, 5,000 or 10,000 lives have since been expanded now to 25,000, 30,000 lives, and clearly more revenue attendant to it. I guess the one footnote I would add to the report is that while pay for performance is viewed as a value-oriented payment, it is not considered a at-risk payment. And to that end, I would just point out, as I did at our pre-meeting call, I'm aware that a number of plans use a withhold of their fee schedule with the provider community, and that pool of money is used on an at-risk, if you will, basis in terms of paying for performance, as well as, I'll call it, additional bonus if there is extraordinary performance. So to that end, for those deals, at least from my perspective, there is an element of risk to that payment, and maybe we want to consider that somehow as a footnote going forward. The plan versus state baseline, I mean, it wasn't mentioned here, but I think a value for the plans is that I know Andrea did reach out to all the plans that participated, and the ability for plans to go in and check their own data against the state numbers is useful. Plans clearly are competitive and like to see how they are faring against national standards, either on a quality basis or on value-based payments, in light of our efforts here at the state level with government working on either DSRIP or on the commercial side on value-based payments. Certainly the data does validate that there are a number of initiatives underway in New York and different models going forward. In terms of value-based payment, I just wanted to make a couple of comments. One is that clearly fee-for-service is still king in the state. And I think in part that reflects something somebody I had worked for at a senator's office, is that the saddest words in the American lexicon are that we've always done it that way. And I think that is part of a culture and business model that has existed in the state. And to try and change that is difficult, and not only takes a lot of time, but it also takes resources in terms of manpower and cost. Provider readiness is an issue that plans are confronting, as they go forward, and we're starting to address that both in the SHIP discussions and in the DSRIP discussions. And there's a significant difference between, the large IPAs in the state in terms of their resources, their leadership culture, their willingness to have an IT system in place to engage in some of these value-based payments, versus, the sole practitioner, the 1 and 2 member practice who are just struggling to survive in terms of their practice. Another significant issue I want to raise, which factors into the timing and the ability to scale up here, is that I continue to hear it at all the meetings I go to, is how this needs to be standardization. We need to make this a multi-payer initiative. I would just say that it is extremely difficult to get all the plans to agree on the measures. And when I say the measures, I just don't mean the NCQA set standards, but all the detail of measurement that comes underneath those measures. The financial commitment and how this is all intended to sustain this change going ahead, and to harmonize the values that exist in and amongst plans to try and get them all together. Plans will put different weight and different value on different measures and their approach to a given market. Clearly no one size fits all. And that runs counter to the goal of standardization that a lot of people are pursuing. Final point I want to make, and it was reflected, I think, in part on some of Andrea's slides, is that less than 3% of the commercial payments are at risk. Health plans want to see at-risk payment proceed. shared savings, pay for performance, things along that line are just steps on a spectrum towards, I'd say, an ultimate goal from a plan perspective. And that is having the providers have skin in the game in terms of performance here. And we need to really focus on that. That's a difficult issue, probably is the main chasm between providers and plans getting together on deals. I'm aware of some plans that have prospective value-based payment deals sitting on their desks, but they only address shared savings. And there really isn't a commitment or a willingness by the providers to take on some of that risk. That will require government to play a major role in how that proceeds, but it is probably a key to getting to true value, generally. I think as you started today's conversation off, at least for this panel. Those are my comments.
Thank you very much. So Bob Galvin, who is the CEO of Equity Healthcare and has been involved in these issues for many years.
Good, thank you very much. I was going to speak with two hats today. One is an employer, and the other is actually one of the two founders of the Catalyst for Payment Reform. So I just can't stop and say, what a great job. And the four employees are four women who run this thing, and they have really catalyzed a lot of change in the country. So I thought it was terrific. And so let me go back to my employer hat for a second. I'm sitting here with a lot of pride. So I'm going to talk about three things, which is, kind of why employers care about this, what we think about these results, and where we think this needs to go. So I think the questions about, the technical questions are incredibly important. You always see that at the beginning and when something's transparent. So, but I'm going to move it up a level just to reflect on it. So, again, employers are somewhat invisible in the system, except almost everyone in the room here probably gets their health benefits paid for through employers or sponsored by employers. And despite a lot of change in the system, my bet is employers continue to stay very active. And what they always have wanted to know is, what are we paying for? And we want to pay for the best value we can pay. This state, I worked at GE before I came to run Equity Healthcare, and so we were upstate in Schenectady of the power systems. We were in this town in the financial area as well as NBC for about 15 years. So this has actually been always a very active state. I'm kind of new here, living here, and the New England Business Group on Health for years was the New York Business Group on Health. And Goldman Sachs, Verizon, CBS, NBC have all been active. So today what I do, just by, again, way of background, what we do at Equity Healthcare is we buy health benefits for about 50 companies. It happens to be I'm owned by Blackstone, that private equity company, so I work for that company and about 5 other private equity. They buy other companies. My team goes in and helps manage their health benefits. It's a couple of $1 billion of health spending. In New York State, it's somewhere around 50 or 60 million. So we're trying to figure out, what do we get for that 50 or 60 million, and how do we understand it, and how do we help drive the system, because we kind of are giving money to health plans that ends up going to providers. So just what do we think of these results? And let me do a little bit of framing. So probably 15 years ago, a number of large employers kind of coalesced around that system. At that point, if you remember, managed care, the tight HMO movement had kind of fallen apart. We were back in double-digit increases. And we tried to just simplify what we thought we could do in the system to say we're going to drive towards 3 goals. The first is measuring quality, so we had some idea of what was going on with our employees. The second was, once we found it, we wanted to pay for it. You get what you pay for, and so once we could define it well enough, we wanted to pay for it. And the third was, everything has to be transparent. We believe that every employee, every consumer needed the right to see everything, whether it was about quality, whether it was about payment. So I think the kind of first impression that I would say on part of employers is, this is a big celebration today. This is terrific. This is the first state that's done this. We did this nationally, commercially, so next week we have a similar event about Medicare, who did it nationally. But hats off to the foundation in New York State. This is not easy stuff, as anyone on the advisory committee would tell you. And if you think there are technical questions now, as a board member of CPR, this is really difficult to get to this point, and we will continue to improve. But hats off to New York. So I think there's a celebration. I think you cannot underestimate the changes is for plans, but far more for doctors and hospitals to now be paid increasingly and have it made public on kind of the things they do. It's just a gigantic change, and I don't think we should underestimate it. I think that it's not going back. I think it's irrevocable, and it's a very big deal. You see it in every organization. So could you put on my first slide? I just have almost no slides, they're pictures, which is, I found the best way to communicate with business people is with pictures. So it's going to be really non-technical.
Can you see it?
Sorry.
Well, what we do, but you're going to be very surprised at these slides. Yeah, that's great. So this was, Andreas said, well, back in kind of the year when we founded the Catalyst for Payment Reform to catalyze payment reform. I don't know if any of you noticed the logo on Andreas' slide. CPR is someone holding a defibrillator to the map of the country. That's what happens when you let me make the logo instead of paying someone in the city to do it. But the idea was we wanted to shock it. Back then, we didn't know the number, but we thought it was very, very small. This was really about 7 or 8 years ago when we decided to start this. And so it was a big deal at that time to say that by 2020, we wanted 20% of payments to be value-oriented or value-based. So I think you've already exceeded that today when you look at the numbers. Fee-for-service and risk is another issue from just simply including quality in payments. And you've exceeded that. The national number has exceeded that. I can't tell you the Medicare numbers, but no one has fallen short of that yet. And so the issue is, what does that mean? Does that mean that we've succeeded? And then go to the next slide, because I think this is my point, and this is why if we celebrate with caution. And that is to say, you're all, I assume most of you are healthcare people in here today, so you know there's one law that rules healthcare. It is the law of unintended consequences. So whenever we try to change the system for the good, we need to anticipate kind of a bunch of consequences happening. And so I would say that from an employer point of view, and in next steps I'll tell you from the CPR point of view, this is about value. So we somehow, and part of it is by the scorecard, by setting targets, and the Secretary of HHS has set out, I think, 90% by 2018 or 80% of all the payments are going to have quality. We've kind of set up a race, ironically, about volume. So we're trying to get around paying for volume and fee-for-service, and we set up a race to say, I'm 60%, I'm 75%, I'm 82%. And so we have decided to kind of change the target and really change the bullseye. And the bullseye means you get value. And so at the end of the day, if consumers, if patients don't feel that the system is better for them in terms of responsiveness, openness, quality, I think that 110% of the payments that are value-oriented won't have achieved our goals at the beginning. So I think that's employers from the CPR point of view, and next steps is to really define this. And I think that we have set out the scorecards because the idea was, we believe, I think like most people in the room do, that if you don't measure it, you can't manage it, and if it's not visible, you don't even know what you're managing. That being said, and as the technical questions showed, you've got to get it right once you do it. I mean, we need to be a learning system about this. So our aim at CPR, and employers are the ones, along with a lot of Medicaid programs now who back it, is to say, okay, we're going to keep on that volume. We think we're going to hit those numbers, but we need to continue to kind of measure based on the value created by value-oriented payment. And so with that,
I guess you might exactly how do you focus it on the center of the bullseye as opposed to this. So we'll turn to Val Gray. Thank you for being here, Executive Vice President of the Hospital Association of New York State, and a person who really knows the state and state government very well.
Don't hold that against me. Good morning. I want to echo the thank yous to the Health Foundation and the Catalyst for Payment Reform. As everyone has said, it is vital to know what the baseline is. And when I look at the report, to me, it sort of it validates that there really is innovation that's already occurring. But that even when you look at the commercial report versus the Medicaid report, They're different markets, they're in different places, and we always need to be cognizant of that because the starting point matters. And, you know, I don't think there's anyone in this room that would say they're not for value-oriented payments, right? That's like motherhood and apple pie. So I think the challenge really is about being thoughtful in how you get there, to your point earlier. And I think we also don't want to lose sight that some of the value-based arrangements in some ways are still largely experiments. To Andrea's point, you know, we want to, I don't know if they're really proven yet. There's mixed results. You can look at the Medicare Shared Savings Program, other commercial things. We've learned lessons. And I think that it's important we continue to learn lessons as we go forward. And I guess I would be remiss not to point out that this sort of sea change that's occurring everywhere you look between DSRIP and SHIP and Medicare, it's sort of all happening simultaneously, and it's happening with a healthcare system that I would argue is financially fragile. And so we have to be mindful of that as we move forward as well. So, you know, the collective challenge is sort of how to get there. So I thought about a top 10 list, and it's not going to be funny like on David Letterman. And I'll go through it quickly in the interest of time, for sure. But, you know, the first thought, BBP thought that I had was that it's so important to build the right incentives. And so I was very pleased to see that all of the reporting really clearly quantifies whether it's connected to quality or not. This should not be just about payment. It should be about both. Timing is so important. I think that whenever you talk to providers that have sort of moved, as Paul mentioned, to the furthermost spectrum for value-based payment, it takes a lot of time, it takes a lot of resources, and it takes a lot of competence and expertise. I don't think it's something that we necessarily want folks rushing into. Jim, to your question about risk, you know, it could be very damaging if you move too quickly. That's not to say that there's some value. There's some folks, to Paul's point on varying levels of readiness, there are some provider groups, provider systems, which are ready to run. They've got the experience, they've got the resources, they've got the results. And then there are other providers in the very, you know, the other spectrum where, you know, we need to make sure that there's time and experience that's built up. And so whatever the state does in terms of defining what is value-oriented payments, we need to really continue to focus on that. I think, you know, size and scope does matter. You know, the question about moving toward risk, any publication you read, you need to have scale in order to do it successfully. And while perhaps in New York City that's not as much of an issue, when you look throughout the entire state, there are some areas where you know, you really need to think about whether scale is there to do some of this successfully. And I think that it's important too to think about sort of the totality of the system with all of the changes between SHIP and DSRIP and Medicare and sort of how it fits together. And I guess one of the things that keeps me up at night is, you know, as we move forward over the next 4 or 5 years with what I would argue are very ambitious targets, and we want our targets to be ambitious but achievable. There are a number of things that are in the healthcare system that folks consider public good. You know, surge capacity to handle Ebola outbreaks or natural disasters or the teaching mission hospitals have or charity care. You know, as I sort of project forward, just want to make sure that we think about those things in a value-oriented payment world. And then I'm actually going to channel Jason Helgerson, since he's not here. In a lot of the DSRIP conversations he always has, he says collaboration, collaboration, collaboration. And I think that it's clear we're sort of on this journey or this path, but it's only going to work if the state works with the stakeholders, if the plans work with the providers, if the providers work with the plans and the consumers and the CBOs. There's a lot of collaboration that will need to be done in order to sort of get to our end point. And then to echo what Bob said, you know, we would need to have a constant assessment and reassessment so that we do learn as we go forward. We make course corrections because with anything so broad and new and simultaneous, there is the unintended consequences sometimes that you mentioned. But I think everyone wants to get there, and so we just need to find the best way to get there and still ensure that everyone has the quality health care that everyone deserves.
That was safe.
Thank you very much.
That was 6, yeah.
I skipped some geeky ones.
I was writing them down, Val, because you're a woman, you know.
Well,
I actually
had some data stuff, I had some attribution stuff, and I decided that you really didn't want to talk about it.
I'll catch you
They
later.
can stay out. Questions? Did you still have a question?
Sure. Can we talk about, when we look at the value-based payments, are we focusing on the broad brush, ensuring everyone has a primary care medical home, or the value-based payment particularly targeted at subsets of populations that may have multiple chronic conditions that we're going to acknowledge are going to be particularly challenging but could benefit the most from value-driven payment approaches and integrated care?
I'm kind of a quality measurement geek, so I'd be happy to take that one. And the answer is we have to focus on everything, but to be honest, the state of maturity of quality measurement is pretty immature. So we're still a little bit in the kind of looking for the keys under the lamppost. The good news is that I think the government, the federal government, gets it. There is kind of, the IOM came out with an important report yesterday in Institute of Medicine on what a core measure said, I guess 2 days ago. And it really focused on the places where there aren't measurements and finding funding for those, meaning multiple chronic illnesses, kind of making sure that you measure if it's readmissions and someone lives in an area with no facilities to go to. So I think right now we don't have it. I think the momentum is good. So the goal is to have it all, but not wait for that.
Yes, Chris.
Hi, Chris Kohler from the Millback Fund. This is a question for Bob, beginning with Paul's comment about multi-payer alignment. Can you sort of maybe draw a chain or a trajectory, since we're dealing with arrows, around moving from your value-based payment goal to getting payers, the process for getting payers aligned, so that we're sending consistent signals to Val's providers? What the role of employers is, particularly the self-insured folks.
Yeah, no, I think that's right. I think, again, if you want to make this work for consumers and patients in the end, somehow providers have to get a clear signal. And what happened in quality, as I think many of you know, because that was about 15 years old, the resurgence of it is everyone came up with their own quality measure. So if your poor provider is sitting there, and I ran a medical group, at a time, you don't know which one to kind of answer because there's so many of them, and you end up having a big department of people just trying to figure out what quality measure to answer. So part of the reason for getting CPR together was to not repeat that. So I think somehow you have to do that without, you have to have some kind of standardized approaches, and I think we're getting there in payment because we're talking about bundling medical homes, capitation, and certain risk corridors, but without colluding about it. And so I think the goal is there. I think large employers do play an important kind of role to help oversee the system because plans are going to go their way, providers are going to go theirs. And so I think we're aware of it. It isn't easy, but if you can have a standardized diversity or something, because it needs, there are, areas are unique, kind of different socioeconomic groups are unique, but there is a clear understanding that there has to be a standardization.
Yeah, and it's hard because a lot of that alignment is happening at the state level.
Correct.
SIM,
Right.
district, and self-insured don't want 50 different choices for their 50 different locations.
Yep, it's a challenge.
Yes.
So I'm just curious if maybe even each of you could, so small providers that have critical population expertise, SMI, SUD, HIV, who don't have the volume to take on risks, and whose viability is challenged for when you move into a payment withhold associated with a good day down the road. How do those folks who traditionally are serving what the old conversation, the 25% that costs 75% on the Medicaid side, how do those folks fit in? What?
And the special needs population.
Yeah.
And the minority population.
So, you know, I think for me, that's like the thing that we're not talking about that I just feel eager to be included in our conversation.
I would just quickly say that I think those providers are vital to all of this, and that I think going back to the collaboration, they need to be part of the partnerships that are struck in managing the care of populations and contracting with plans to do so in the value-based world.
Yeah, I'm happy to be in a spot state here. I don't think fee-for-service is evil. I think it's misvalued many of the cases. I think there are going to be cases where putting risk around it is not the way you want to go. Now, if you're a big Montefiore, if you're a mature system that understands, and it takes a long time to get there, how you would kind of price those people, how you care for them, and you're willing to take risk, and someone says, yeah, these people really know it, that's fine. I think if you go to the other parts of the state, this is my personal opinion, I'm probably not speaking on behalf of all employers, I'm speaking on someone who's done this for a long time. I think fee-for-service, if you reset some of the values about what people get paid how much for, is perfectly appropriate in those situations. That's one personal.
Can I just add to that? I think that one of the stark zeros on both the scorecards, right, were the sort of zeroed in or near zero bundle payments. And I think with particular subpopulation expertise, our ability to align and utilize district CHIP and Medicaid redesign to build integrated care delivery systems that allow smaller niche providers to deliver more of the care, to affect more of the outcome with more of the healthcare dollar, is a pathway to building the capacity within those systems to look at other ways. But I think if we move too quickly, and one of the things that's really important to me is just that 0 at 1% of the bundle payment structure.
So that's why I add is, as we move toward high deductible plans, I think a bundled payment often will make sense to a consumer who has to pay for something. It's sort of a product as opposed to a bunch of activity. So I think there's a lot of...
Yeah, the one caveat to that, I wouldn't, as a buyer, I wouldn't buy that unless I had quality measures that assured me in those special conditions that you weren't doing better by doing less. So I think once you have those quality measures, I think bundling is the...
And it impacts the 8% of those emissions that are re-emissions.
And I think based on what you said, even citing Medicaid, DSRIP, et cetera, it's really an important role for government to play as it relates to those services and those providers, because you're not the same. You're not the same as the balance of the system.
And a health plan isn't necessarily going to be able, through payment, to redesign and drive the quality or build the integrated systems. It's really going to be government and our agencies that help drive that.
Yeah, Neil Kelman, Institute for Family Health. So I wanted to just address two comments that you made, Paul. One was that health plans had all these things on their desks and they were just waiting for providers to sort of be ready to take them, had all these value-based plans on their desk. And the other was that they're waiting for providers to have skin in the game, to be able to take risks. So two things about that. I think one is not only if you're just a special needs provider, but if even for us, we're one of the largest community health center networks in the state. We have 100,000 patients, but they're divided over 25 health plans. So you can have a fairly big population, but because of the number of plans that exist in New York State, you don't have enough members in any one plan to really get to play with that plan. Second of all, we have 6 risk-based sort of contracts now that have value parameters built into them with 6 different health plans. They're all different, and in every one of those cases, we have to go to the plan. Sometimes it took 2 years for us to get them to agree to some sort of value-based payment. So I don't think there's as many of these sort of ready-to-roll plans out there. Each one of these feels like we're sort of co-developing it with the plans, and so I think that there's a need to continue this dialogue back and forth between the providers and the plans. And in terms of the skin in the game piece, the skin in the game for the providers and for the plans are different. You know, the plans are in the business of taking risks. That's why they're a health plan. If they're not going to take risks, they might as well not be a health plan. They can just pass the risk on to somebody else. We don't really need them as middle people if we're going to take risks, you know, to that extent. I think that the risk that we take has been in the redevelopment of our entire delivery systems, the investment in care management and IT and all of the things. We have upfront risk that we've been sort of upfront skin in the game that we've been putting in for years in order to sort of be prepared for this predicted change that's happening very quickly. And so I think when people come to us and say, yeah, but we want you to take financial risk, you know, what I say is we've been taking financial risk for the last 2 years, getting ready for this period of time. You take the financial risk on the insurance side. That's why we get the big bucks. And we'll take the financial risk on the provider side by recreating a delivery system that's substantially different than the one that we've had before and much more costly on the front end.
I'd agree and then disagree.
Okay.
So, you know, from the plan side, you know, you're investing to get ready to improve quality or do value-based contract. There's an investment to it. There are investments on the plan side as well, not as great as on the provider side, but there are investments there as well. But the skin in the game is critical because while we're all sitting talking about improving quality, there is a cost component to all this discussion. Somebody's got to pay for it. And people, as part of value, part of that definition has to be some sort of efficiency factor. So you can have, you know, improved quality, but if the cost continues to spiral out of control, then people are going to say, well, that's not value. So there's a belief.
I mean, I guess my point was not that we like shared savings kinds of arrangements, but in terms of taking insurance risk for these small populations of people, it's really not a healthy place, I think, for providers to be. I mean, you have 2,000 members in a plan.
So let's stop. So the risk side, it goes to the scale. I mean, which Val alluded to too. You've got to have the scale. So the deals I'm talking about are larger groups or hospital system or ACO models. You know, ACOs are clearly part of the value-based discussion. We're focusing on, you know, advanced primary care, but ACOs are part of that discussion too. And there you're going to have greater scale, and there's an interest in sharing some of that risk, you know, to make sure that the whole venture proceeds and both sides benefit from that deal.
Craig, I'm going to be channeling Valerie's inner geek for a second. Value-based payment for me falls into a couple of different buckets. One is essentially pay for performance and its spawn. You do better at this, you get a cookie in one form or another. And that almost anybody can play because it's sort of like provider performance specific. Any provider can have one of those deals and they can make some money, or they can earn back the money that was withheld and possibly some more. And then there's the sort of like the shared savings, shared risk, full capitation game, which is different because it drives off of attribution, and it is made real by risk adjustment. And those are two of the really critical issues. So that if you take the shared savings that as a system, it drives off the primary care, and as who's attributed to, it matters how that gets done. And then you have a benchmark you've got to beat, and that really drives against, are the benchmarks really based on your patient population, or are they something artificial or not really relevant to you? You have a sicker or a weller population, you do better or worse on these things. So the techniques of these things are really pretty complicated, and providers don't really understand it. I mean, it sounds like if you're a real man, you'll take risk, and the answer is if you're not prepared, you're not going to do very well. So they've got to have a delivery system that does the stuff that Neil's talking about on the primary care management side, but you also have somebody who's setting the game up has to get those things right.
Yeah, I mean, it's not like we haven't done this rodeo before. We did that risk when people weren't ready in the 90s, and it didn't end well. So I think you're right. I think what we found is kind of the cookie, on the individual provider doesn't really transform the system much. But I think, they talk about these 3 R's in health reform. It's risk adjustment, it's risk corridors, because that's not perfect. And then it's some kind of reinsurance. I don't want to get too techie here. But I think you're right. You have to be really thoughtful about how to do that.
Last questions, you ready? Great, well, we're going to end pretty much on time. People will be around if you have other questions. Thank you very much. Did you have the...
Yeah, I just, for the question about numerator and denominator, in case anyone is so the denominator for the commercial market was 29 billion, and the numerator was 10 billion. On the Medicaid side, the denominator was 11 billion, and the numerator was 3.6 billion.
Good. Thank you very much for coming.